All right. Good day, everyone. I am Carrie Benton. I am the Director of African and African American Studies program and an Associate Professor in History. And I'm here to bring you greetings from our program. Back in 2019, we celebrated the 50th anniversary of the African and African American Studies program here at the University of Arkansas. And in the spirit of Sankofa, we had the opportunity to reflect on the past and honor the legacy of the many visionary unsung heroes and pioneers who have paved the way for the kinds of rigorous interdisciplinary program that we have that promotes academic excellence. We therefore invite you to come and study with us, to pick up a minor or a major in African and African American studies. Now, one of the features of our program that we're especially proud of is the African and African American Studies lecture series. In this lecture series, we feature a diverse range of lectures, performances by scholars and experts. The lecture series indeed bring to campus a broad spectrum of talks, information about political debates, cultural events, and so on. And so in the past, we've featured the likes of Dr. Alan Morris, who gave a talk on the scholar denied W.E.B. Du Bois and the birth of modern sociology. We had Dr. Carl Anderson, the author of White Rage, who gave a lecture on 1 year later, Where Are We Now? And the cultural context leading up to the 2016 presidential election. We had Nicole Hannah-Jones, the creator of the 1619 Project, who gave a lecture on understanding modern day segregation. And the last person we had before now was Casey Lemon, the winner of the Carnegie Mellon Excellence for Nonfiction, who gave a talk on his book, Heavy. So this year, we have decided to do it in two parts with this lunchtime colloquium that you're now at called Pandemics, Medicine, and the Black Community. And let me tell you, you are really in for a treat as this panel features the works of academics, scholars, and professionals that works on different aspects of wellness and health in the Black community that truly highlights not only our interdisciplinary perspective that we bring in African and African American studies. Indeed, we have scholars from history, biology, sociology, and a local doctor that showcases the vital importance that we also place on our community, right? On bringing the community and the university together. I hope you will join us tonight for a keynote lecture from a scientist from the Centers for Disease Control and Prevention, Dr. Ernest Ufenyiwe, who will be speaking about containing contagions, the overlapping pandemics of HIV, COVID-19, and the global Black community. For this effort today, African and African American Studies is fortunate to have collaborated with various organizations such as the Pat Walker Health Center, the College of Engineering, the Honors College, departments of biology, history, English, the office, the Walton Office of Business, Diversity and Inclusion, programs in the medical humanities, the Office of the Vice Provost of Diversity and Inclusion, the Fulbright Office of Diversity and Inclusion, and so many other programs as well. All of these lecture series are free and open to the public. So we thank you for being here with us. And I will now turn you over to Dr. Trish Starks, who will get you started. Thank you.
Thank you so much. I want to thank Dr. Benton for inviting me to be part of this panel. Dr. Sinitra D. Hughes, who's the Managing Director of the Dr. Barbara A. Lofton Office of Diversity and Inclusion, and Sarah Hughes of the African and African American Studies program as for all of their work in organizing this. And I'm so very excited to be part of this. I am Trish Starks. I'm a professor of history and director of the University of Arkansas Humanities Center. And it is my honor to be part of this panel and to be part of a discussion that I don't often get to have. Right now, I'm teaching a course on the history of race and medicine. And my course is much more focused on the heroic past of many of our, or the non-heroic past of many people who have been put forward as heroes of medicine, such as Dr. Marion Sims, the father of modern gynecology, or Dr. Benjamin Rush, who was the first Surgeon General. These men who have been put forward as heroic, I have dealt with not in the terms of where they have treated people, but where they have used their power to not treat but abuse, to not help but harm, and how their heroic therapies that they then gave forth, born of blood and agonies from African Americans, minoritized populations, and other marginalized communities, have not then been allowed to be benefit to those very same communities. My class has been filled with the long and complicated relationship of Black and minoritized people's relationship to medicine and science. Most would associate it more fully with the Tuskegee experiments, but we see that there is a much deeper and longer and broader history of abuse and non-treatment and problems of access for African Americans and other minoritized groups. I'm so excited that today, instead of talking about these grim stories of the past and these non-heroic passages, we get to talk with true heroes who are working on remedies for these problems, working towards research and scholarship that will overturn these injustices, that will bring access, that will show the problems that are born of the past and give us a pathway to a more just and equitable future in healthcare and in treatment regimens. These are people who are working to overturn these problems, who are working for the Black community and other groups. And I am so excited to see how they make a true heroic future for medicine in a past that has been overcome with injustice and problems. We have been joined by three fantastic scholar, educator, practitioners. I'm going to start by introducing each of them in turn. Each of them will speak for about 20 minutes, and then we will have time for questions at the end of the session. If questions occur to you as the talks are going on, please feel free to share those in the chat. We'll be monitoring the chat so that we can have those ready for them after our three presenters are done. And that way you can give questions as they occur to you. I know sometimes questions come to you and then you forget to ask them at the end of the talk. The chat gives us a lovely function to work with that. We have three presenters, Dr. Steve-Felix Belinga, Dr. Brittany Hearne, and Dr. Tameka Bailey. I will introduce each and then they will talk and then we'll move on. So our first speaker is Dr. Steve-Felix Belinga. He is an MD and board certified general neurologist from Fort Smith, or in Fort Smith, Arkansas. He is one of only 2 fellows of the American Academy of Neurology in the state of Arkansas. He graduated from Wash U in St. Louis at their School of Medicine in 2008, an exceedingly prestigious school here of medicine in the middle of the country, tops in the Midwest. He completed his neurology residency program at the University of Kentucky Chandler Medical Center under Dr. Joseph Berger in 2012. He has been in practice since 2012 and works at Mercy Neurology Clinic, Fort Smith, and Mercy Hospital, Fort Smith, where he has built the neurology service and the primary stroke center. He now has his own clinic in the heart of Fort Smith, where he specializes in Parkinson's, Alzheimer's, epilepsy, neuropathy, migraines, and many more neural agencies. He is going to talk on trusting your doctor, the patient's perspective, and I'm so very happy to invite him here. And I am going to mute while he brings up his own screen.
Well, hi, everybody. It's a joy and privilege to be amongst you guys and to share a bit of a practical perspective of truly what you would guess, what you would know, what the scholarly research says. It's a little different from a doctor's perspective because it's not demographics. These are the real folks in front of you. And again, as a physician, there's usually an issue to solve, and grasping the person in front of you, grasping the patient in all their complexity, in their entirety, is actually a critical step in the process. So I wanted to give a little bit of an overview of where things stand, and it's very similar to what's been said already, and kind of move forward into how the patient actually perceives their physicians, kind of, a snapshot at it, and again, how the pandemic has affected all this. So unequal access has been widely documented throughout the studies. Minorities and African Americans in particular do not have equal access. In neurology, it's even more pertinent because African Americans are 30% less likely to go see their doctor as a visit, but African Americans are more likely to go to the ER. They're more likely to have severe conditions. They're more likely to have longer hospital stays, and they're also more likely to have more costly hospital stays. All these things kind of go together. Their conditions tend to be more acute, tend to last longer, tend to be more severe, and requiring a lot of expense and a lot of care. And there are a few reasons for that. And unfortunately, there are quite a few. There are many. Minorities and African Americans may mistrust the system. They may misunderstand the system. There may be differences in the cultural beliefs or attitudes. So let me back up a second. Mistrusting the system is what you would relate to the Tuskegee experiments and all those nasty things that happened in the past. Misunderstanding the system is perhaps worse, which is, well, once there's that past, well, how do you trust a system that says we want to care for you now? And are those resources even available to explain that clearly? Also, different cultural beliefs and different cultural attitudes play a major role here. For some, aging, growing old, making mistakes, having problems is quite natural. And for some others, it's not. Where do you define the line? When someone starts to have memory issues, at which point do you decide, well, this is too early, and we need to get care, or, well, it's just what it is. And thinking in a certain way or another may actually reduce your access to healthcare. We talked about limited social support and resources. If the community around you is not pushing for you to go to doctors, you are less likely to go to doctors. If the folks, your friends, don't rush you to get help when you should, or as early as you should, likely you may not get the help when you need it the most. There's also less resources, physical resources. We have less providers. We have less primary care physicians available in general. This is actually a systemic problem in medicine, but it does seem that African Americans would have less access to primary care providers because there may not be enough where they are. And if you have fewer general practitioners, you will have fewer specialists. And if you have fewer specialists and fewer practitioners in general, then you're more likely to present with situations that are worse because you never actually got access to that healthcare. There's also an issue about insurance coverage. And as we said, there's also an issue about health literacy. There are subtle differences, but these are actually separate items that all affect the fact that our community in general does not get access early to healthcare and get their problems treated early as they should. So trusting doctors is a very interesting topic. It's very much a patient perspective, not so much a physician. And as a physician, and I believe most physicians would probably say, of course, you need to trust us. Of course, you need to trust me. Now, for some of us who've been to the doctor, who had to be a patient, it's a little different experience. Even I might say, to a certain extent, I may even dread going to the doctor because, well, do I really want to hear what he's going to say? And am I going to trust that he's going to fix something that's that no one can see on my body. Okay, maybe an MRI scan can see it, but I can't see it. So how is he going to see it? So there's a lot of difficult issues already just because one is a patient and one is a doctor. And then you add the complexity of culture, the complexity of ethnicity. And I got these words from my patients, actually. I wanted to hear what they had to say, what they felt like, and try to be in their shoes and just getting their words. And I said, as a whole, doctors may not even listen for the most part. And yes, I'll admit that most doctors, including myself sometimes, we just don't listen. And having, say, a non-ethnic doctor seems to present a greater challenge in terms of listening. Patients perceive that because of the cultural difference or because of their particular emphasis on an item or another, the doctor on the other side, who is not from the same ethnicity, may not perceive that as being an issue, or may not understand the cultural context, or may not understand the past of the particular person or the particular group of people. That's one significant issue that I heard over and over. Another thing is, because of that mistrust, now you're having difficulties as a patient expressing your full concerns to your physician. He's probably not going to listen to me, and he may not understand what I'm talking about anyway, because he's not one of us. And as a result, I don't know if I should tell him everything. I don't know if I should tell him certain details because, well, he's not going to listen. So I'm just going to hold back. So, you know, it might be difficult to frame that scientifically, but this is what the patients actually report. But, well, do you get that with your so-called ethnic providers? Do you get that with folks from your race? Or in other words, what makes it so special to have an African-American patient go to, say, a Black doctor? And there, again, it was a learning experience even for I, to say, well, when I see my Black doctor, literally, this is what a patient said, well, I can trust them because I know they're a really good doctor. And I said, well, why would they be a good doctor as opposed to the other one? One of the things they really said was, I know that he's had to work twice as hard to get to where he is, which means I know he had to suffer twice as much. And I know that he, as a result, must care twice as much because he's really wanted to be there. He's really striving to be in this position to be able to help. So I'm going to trust him because of that, because I do believe somehow he's overcome more adversity. And as a result, he's going to be a more caring patient. And this is just from a cultural perspective. This is not about degrees. This is not about accolades. This is not about which school you went to. Normally, I'll tell you, in the medical field, they tend to compare physicians according to which schools they went to and what specialties they're in. Are they a general practitioner versus a specialist? Well, patient perspective is basically, well, how hard have you had to suffer to get to this point equates how much you actually care. And again, spoken from a cultural standpoint, African Americans would have it more difficult. So they perceive that as being a higher achiever, therefore somebody that could be trusted better. Another thing that you really wouldn't think about in terms of a provider, I see a patient, I really want to help them, I really want to make them happy. But then the flip side, and something I got again over and over, was, well, you know what? I really like you because I'm happy that you're here and I'm happy to see you successful. Goes again in the culture, the fact that that shared history, that shared culture seems to put people at ease, and they're happy to see you succeed. And as a result, they want to be with you. So it's that sense of belonging, and that sense of belonging with someone, one of us who's more successful. Again, that is not typically how you would think as a physician that your patient sees you, but this is what they see. It's a component of their satisfaction with you. The fact that you're caring for them, you're happy doing it, and actually you're doing it and you're one of them, matters to them. So that's another thing that I got. And as a result, they feel more comfortable because they believe that you're not going to judge them for who they are. You're not going to assume that whatever condition they're having is, say, a drug-seeking behavior, or it's some type of conversion disorder. They think that, and this is, again, their own words, that because you're one of them, because you share that culture, you share that history, you will understand them better. Again, this is not what they teach in medical school, and even in the ethics class and in all the sessions where you learn empathy and you learn how to care for patients. That did not come across from a very cultural perspective. But you could see that putting a patient at ease in their own culture as you speak to them makes a big difference. So my Black patients want to trust me because of our shared culture, of our shared heritage. And again, that they did not teach that in school. So I'll add a little bit about the pandemic. So what did the pandemic do? Well, clearly it wasn't going to help. And unfortunately, it may have made things a little worse. We're talking again, socioeconomics affecting certain minority groups more than others. So again, I don't have any hard evidence, but overall, there may have been a slight drop in the number of visits from African-American patients as compared to the past. Now, I do hope that as COVID ends, this is going to perk back up, and as hopefully, as we make ourselves more available to patients in our own community, they do come back and they want to trust us more. So I'm not going to talk about solutions. I think there are folks better qualified to discuss matters of health policy, matters of health literacy, issues with bringing more doctors to all the communities, and issues of bringing more specialists to the community. But in summary, access is unequal, and there are systemic issues as to why. But that inequality results in more acute care, more severe cases, and it would help for truly cultural education for some of our physicians, including our very own physicians in our own community. We're trained to be quite logical, quite scientific. I don't think the cultural training is quite there yet. It's something that some of us have to relearn on the ground, and you might even be shocked. Your own culture might shock you, and that is surprising at times. Thank you.
Thank you, Dr. Belinga. That was fascinating and a wonderful way to phrase it, not just the things one doesn't learn in school, which we all have encountered, but also that discussion of mistrust and misunderstanding. I liked how you phrased and separated that out. I know that you have an issue at your clinic. Are you going to be able to stay around for questions later?
I might not be, because I have to get back to work, but I'll be happy to answer some of those questions later.
All right, well, I'm going to urge anyone that has questions for Dr. Belinga to go ahead and drop those into the chat, and we'll try to take a break between our next two speakers for any questions specific to you. And that way we can make sure to have any kind of interaction that questions that people have for you, because I know that I have questions that we can get a chance to get to some of those.
Absolutely. I'll try to get through some of them via the chat as soon as I can.
Okay, thank you very much.
Thank you.
Let me turn now to our next speaker, Dr. Brittany Hearne. Dr. Hearne is assistant professor in the Department of Sociology and Criminology here at the University of Arkansas. She has her BS from Texas A&M and an MA and PhD from Vanderbilt, where she got her doctorate in sociology, as well as a graduate certificate in African American and diaspora studies. Her research engages socially patterned variations in the areas of health, family, and social psychology. And specifically, she uses quantitative methods to examine how race, gender, and educational attainment intersect to produce unequal outcomes in issues like depression, in concept, in romantic relationships, and in parent-child relationships during the transition to adulthood. Currently, she is working on a project in which she analyzes the impact of romantic relationships on self-concept and health for Blacks and whites by educational attainment during the transition to adulthood. She has also been working on issues of COVID and COVID in relationship to the Black community here in Northwest Arkansas. And I'm very excited that she is going to share with us some of the results from that research in her paper, which is entitled, "I Recognize My Privilege: How College-Educated Black Americans Manage Stress During the COVID-19 Pandemic." Thank you so much for joining us, Dr. Hearne.
Thank you, Trish. I'm going to actually share my screen. Okay. So good morning. Once again, I am Brittany Hearne, and as stated, I'm an assistant professor in the Sociology and Criminology department. I want to thank the AAST program for the kind invitation to speak, and thank all of you in the audience for taking the time to be here. The title of my work has changed slightly, but the gist is still there. I'm presenting highlights from a project titled Psychological Distress by Race, Ethnicity, and Education at the Onset of the COVID-19 Pandemic. And specifically, I am presenting the quantitative findings from this research. Just as some background, this study was motivated by my interest in racial and ethnic health disparities, both physical and mental. And often I approach my projects using elements of what is known as the stress process model. The stress process model is useful for understanding mental health outcomes as a consequence of social phenomena. In other words, the stress process allows for the acknowledgement that our health is an outcome of multiple things: biological, social, and environmental. So I would like to begin with some definitions to get us started. Throughout this presentation, I will use the terms stressors, distress, coping, and coping resources. Stressors are events or conditions that are demanding, threatening, or challenging and require adaptation. And you might immediately think of the pandemic and its consequences for our social life as stressors. Distress is a possible negative consequence of stressors. And in sociology, we often measure distress as a sum or an average number of psychological disorder symptoms within a non-clinical sample. Now, you may have noticed my emphasis on possible negative consequences. This is because the stress process model suggests that the negative impact of stressors can be reduced with effective coping resources and strategies. Coping includes any focused attempt to manage situational demands or stressors, and resources include psychosocial or material assets that assist in adapting to stressors. So examples of coping resources include things like a high level of education, high income, high mastery, or the belief that you have control over your life, and high self-esteem, or thinking of yourself positively as an object. So for this particular study, I began with two broad thoughts from previous literature. And the first is that stressors, especially those that are unexpected, are associated with increased psychological distress. And you may remember that the COVID-19 pandemic was completely unexpected. Psychological distress is a measure of both depression and anxiety symptoms. So more plainly, psychological distress is a general measure of overall sadness and worry. The second thought I had is that people with coping resources are better prepared to manage stressors to curb or reduce psychological distress. So these two broad thoughts are generally applicable. But some racial and ethnic minority groups like Black and Hispanic people were more likely to face the pandemic from a socially disadvantaged position and often with fewer coping resources. Thus, although the pandemic was unexpected for everyone, for those in socially disadvantaged positions, psychological distress could be worse or heightened. But as I said earlier, stressors can be managed with coping, which requires resources. And education is a coping resource that could complicate the relationships between race, ethnicity, and psychological distress during the unexpected pandemic. This is because education encourages critical thinking and creativity in coping. Education is positively associated with income, which again is another coping resource. And for Black people especially and specifically, higher education is required by gatekeepers to allow access to goods and services. So this brings me to the specific research questions that guided this study. I first examined how psychological distress differed across race and ethnicity during the initial months of the pandemic for a sample of Black, Hispanic, and white people. And second, I examined whether the associations between race, ethnicity, and psychological distress were the same across different levels of educational attainment. To address these particular questions, I analyzed nationally representative survey data. And these data were collected in March and April of 2020 from members of the Pew Research Center's American Trends panel. The surveys are weighted to be representative of the US population. And the analyses are limited to those who provided valid responses on all measures used in this particular study, which resulted in a final analytic sample size of 8,009 respondents. The dependent variable of interest in this study is psychological distress measured in April of 2020. The measure assesses the total amount of psychological distress that individuals reported experiencing in the past 7 days. So that is, survey respondents were asked, in the past 7 days, how often have you felt nervous, anxious, or on edge, depressed, lonely, hopeful about the future, or had trouble sleeping? And they were given the options of responding with 0 to 3. 0 corresponds with rarely, none of the time, about less than 1 day. And 3 corresponds with most or all of the time, about 5 to 7 days, excuse me. So after reverse coding that hopeful about the future item, I added the responses, which resulted in an index or a scale that ranges from 0 to 15, with 15 representing high psychological distress. And again, as a reminder, psychological distress is a measure of both depression and anxiety symptoms. Race ethnicity was assessed as non-Hispanic Black, which serves as the reference category in my analyses, non-Hispanic White and Hispanic. Educational attainment is assessed as no college degree, which serves as the reference category in these analyses, associate's degree, a bachelor's degree, or a graduate degree. I also included, of course, COVID-19 pandemic variables, which were measured in March of 2020, and these adjust for the social changes that resulted in response to the pandemic. The measures assess the amount of change in one's life due to the pandemic, and respondents could say that they experienced no change, that they experienced a minor change or a major change. Those who said they did not experience any changes served as the reference. Additionally, respondents could tell, they were asked whether or not they or someone in their household had lost a job or experienced a pay cut. And those who had these experiences were compared to those without these experiences. And then finally, I include an index of discomfort performing daily tasks. There were 5 total items for this, in which respondents were asked whether they were uncomfortable visiting with a close friend, eating out at a restaurant, attending a crowded party, going to a grocery store, or going to a polling place to vote. And those who said that they did not experience discomfort were coded as 0. Those who did experience discomfort were coded as 1. These things were added, and this resulted in an index ranging from 0 to 5, with 5 representing higher discomfort performing these otherwise mundane tasks. And then finally, I include a number of control variables. These include demographic characteristics, social support measures, and socioeconomic status variables. So that is, I control for self-reported sex, income, age, frequency of religious service attendance, marital status, region, whether or not the person lived in a metropolitan area, and whether or not they reported a prior mental health condition, that is prior to the COVID-19 pandemic. So again, in this sample, I have 8,009 total respondents. Psychological distress ranges from 0 to 15. So here I am showing the descriptives. Psychological distress for the entire sample, the average is 5.24. And in this sample, 12% of the respondents were Black, 16% Hispanic, and 72% reported being white. For educational attainment, 58% did not have a college degree, 9% had an associate's, 19% had a bachelor's, and 14% had a graduate degree. I moved on to do some comparisons of psychological distress across race and ethnicity and across educational attainment. Black respondents, again, on a scale from 0 to 15, reported an average of 5.28. Hispanic respondents reported 5.51, and white respondents reported 5.17. Hispanic respondents reported statistically higher psychological distress compared to white respondents, and this was at a p-value of less than 0.05, which means that we can be 95% confident that this difference in psychological distress actually existed in the US population. Moving on to the education differences, those without a college degree reported an average psychological distress of 5.42. Those with an associate's reported 4.85, with a bachelor's 5.07, and with a graduate 4.95. Those without a college degree reported statistically higher psychological distress compared to each of the degreed categories, and these were at p-values of either p less than 0.01 or p less than 0.001, which means that we can be either 99% or 99.9% confident that these differences actually existed in the US population. From here, I went on to estimate some multivariate analyses, and I won't show that particular table. I do have it available if anyone is particularly interested during Q&A, but I think it is easier to show the results from those multivariate analyses in this graph. So first, I'll walk you through it. On the y-axis, we have psychological distress from 0 to 6. On the x-axis, there is educational attainment in degree categories, along with race ethnicity. As a broad summary, there is a statistically significant and substantial decline in psychological distress for Black people with an associate's degree and Black people with a graduate degree compared to Black people without a college degree. The decline in the averages, that is compared to Black people without a college degree, the decline in the averages is about 1. And in my line of research, this is quite substantial. But racial and ethnic statistical significant differences within an education category only exist among those with a graduate degree, such that Black people reported the lowest psychological distress among the graduates. So if you look to the far right side of your screen, those last 3 bars, Black people reported statistically lower psychological distress than their Hispanic and white peers who also have a graduate degree. Moving on to the white respondents, those with an associate's degree reported statistically lower distress than white people without a college degree. But you may notice that the difference in these average psychological distress between these two groups is not very substantial. And aside from this small difference, the averages across education for white people are quite static, around 5. And then for Hispanic people, there is a noticeable lower average for those without a college degree compared to similarly educated peers, but this lower average is not statistically significant, and overall, education increases are not associated with reduced psychological distress for Hispanic people. So as broad summary, it is only among the graduate degree holders that Black people reported statistically lower psychological distress, which means that among the people without a college degree, those with an associate's, and those with a bachelor's, across race ethnicity, psychological distress was similar or statistically similar. It should also be noted that increased education, especially a graduate degree, seems to be a useful coping resource for Black people in a way that is not especially evident for the other groups considered here. So explanations for these findings for the Black graduates are likely complex, but I would like to advance 3 major possibilities that also tangentially help to explain the findings for white and Hispanic respondents. These explanations are informed by prior research literature, but also interview data a colleague and I collected from people living in Northwest Arkansas. So the first possible explanation for the lower distress among Black graduates is that education is known to offer psychosocial resources that aid in coping generally. So you may remember I said earlier that education helps people to think creatively and to critically think through problems. And so education is a psychosocial resource. For Black people specifically, to attend graduate school and attain a graduate degree despite race-based barriers is a huge success and likely requires coping skills. Thus, not only do Black people gain psychosocial assets from simply increasing their education, they might also develop resiliency. Consequently, when faced with a large-scale stressor like the COVID-19 pandemic, Black graduates have experience with effective coping and can use this prior experience to lower their distress. Of course, selection effects are also possible, which means that the most resilient Black people and those best skilled at coping are possibly more likely to earn a graduate degree and continue to benefit from those coping skills at the onset of the pandemic. Relatedly, and the second possible explanation is that the disproportionate burden of the pandemic for Black people is not new. During large-scale disruptions, things from economic recessions to natural disasters, Black people are more likely to be disproportionately burdened. In addition, those with more education might have increased cognitive resources. And what I mean by cognitive resources is that college-educated Black people, especially those who have attained a graduate degree, are more likely to have some knowledge of this history of how Black people are typically overburdened by large-scale stressors. Consequently, Black graduates can draw on their knowledge of resiliency within Black communities for strength and as a coping mechanism at the onset of the pandemic. And as a third explanation, college-educated and middle-class Black people, socially mobile Black people, are more likely to have close family and friendship ties to disadvantaged others. That is, a lot of socially mobile Black people come from backgrounds that are not quite middle class. Thus, when coping, highly educated Black people can draw on social comparisons to people relatively more burdened by the pandemic, which places their own struggles in perspective. These social comparisons might be thought of as stress appraisal coping strategies in which the stressors are reframed as less threatening. For example, Black graduates may have also faced challenges related to the pandemic, like conflicting work and parenting demands, but they were more likely than highly educated white people to know other people who have it relatively worse. And these other people serve as a potent reference group for social comparisons that can lower their own distress. In other words, I might have it bad, but my close personal friends or family have it worse, and this helps me to reduce my distress. Importantly, these social comparisons require critical thinking, which is a benefit of increasing education, but not necessarily a benefit of increasing income. The bottom line here is that with respect to psychological distress, I would not think of white and Hispanic people as especially disadvantaged because psychological distress does not noticeably decline across education, but instead I'm suggesting that Black people with a college education, particularly a graduate degree, reported lower average psychological distress because of their unique social position as highly educated Black people, which permits both psychosocial resources and distress-reducing social comparisons. Now, in conclusion, Black people experience a decline in psychological distress at certain levels of education, and the same does not appear to be true for Hispanic people or white people. To be clear, very few people and very, very few Black people have a graduate degree. For instance, of the roughly 108,000 doctorates awarded during the 2014-2015 academic year, 61% were awarded to white people, 7% were awarded to Black people, and 3% were awarded to Hispanic people. So these findings should not be mistaken as a sign that Black graduates are especially advantaged, or that I'm talking about or speaking about a large segment of the population. Instead, the few Black people who have managed to earn a graduate degree were psychologically better compared to the small number of their similarly educated peers at the onset of the pandemic. And I would like to take just a few more seconds to say for Hispanic people, there is a complex story here. And considering the findings as a whole, education was not associated with lower distress for Hispanic people. And I surmise that diversity among Hispanic people might play a role in these findings. Hispanic ethnicity includes a diverse set of people with different statuses across nativity, immigration, and race. That is, Hispanic people can self-identify as Black or white, although not the case in the survey. But I do mention this because one study has shown that Black Hispanic people face greater hospitalization and death than their non-Hispanic white peers and compared to white Hispanic people. So the bottom line is that Hispanic ethnicity includes a diverse set of people, and disaggregating this group might show different findings with respect to psychological distress. Finally, I'll just say that Black people are a unique group with respect to disadvantage and oppression, and there is room for and examples of resiliency. While I am not advocating that oppression should be used to make people grateful for what they have, I am suggesting that given the reality of disadvantage for Black people broadly, there are opportunities to see that disadvantage can elicit appreciation and thankfulness that benefits mental health, especially for Black folks who have the privilege of attaining higher levels of education. It is this combination of structural disadvantage and privileges and advantages that education offers that create a unique position for Black people, Black graduates, that helps them to lower their distress during large-scale challenges such as the COVID-19 pandemic. Thank you so much for your attention. This work was supported by the Conner Endowed Faculty Fellowship and the Arkansas Humanities Center.
Thank you, Dr. Hearn. That was great. Yeah, we were involved in that. Yeah, you managed it. I wanted to take just a moment before Dr. Balinga has to leave. We had two questions pop into the chat that I'm hoping, is he still here? I don't see him. Has he already popped off? Yes, I think he's had to leave. Well, we'll go ahead then and address those at the end as part of the Q&A, because he did put some answers, but they were only shared with the hosts and panelists. And so make sure that those come forward. I have loved how these presentations have worked together, how Dr. Balinga's is a real story about how few specialists we have and how that is a point for including more mistrust, and how Dr. Hearn brought up these same ideas of how few graduate degrees we are seeing of minoritized populations, and how those kinds of inclusion and greater access will be so helpful for change. I'd like to move on now to our last presenter, Dr. Tameka Bailey, who is Assistant Professor in the Department of Biological Sciences here at the University of Arkansas. She's from the Delta area, from Gould, Arkansas. She got her undergraduate degree at UA Pine Bluff, and then came to the University of Arkansas for her PhD, where she attained a PhD in cell and molecular biology. Her research interests are managing a lab of talented undergraduate and graduate students who work with her to identify proteins that modulate triple-negative breast cancer metastases and to elucidate inhibitors of these proteins. She has an honors colloquium on the biology of breast cancer, which is a very popular colloquium for anyone who's interested in that or is interested in doing a medical humanities degree. Those go together really well. She is leading a mentoring program as well in the summer for girls in the Arkansas Delta who are interested in science, helping with these very issues we're talking about getting more degrees, more specialists, and more inclusion in our sciences and our practitioner bases. She'll be talking today about the racial disparity of breast cancer mortality in Black women. And I'm very excited to see this presentation, and I'm going to mute myself so that I can.
Thank you for the introduction. So today I'll talk about the research that we conduct in our laboratory. I run a wet lab, and so I'll share a little data that we've generated in the laboratory. And we study triple-negative breast cancer metastasis, and we're trying to link that to the racial disparity and breast cancer mortality, to the triglyceride paradox, and I'll talk about what that is shortly, and a family of proteins called the angiopoietin-like proteins. But first, I want to introduce the group of people that I get to work with. Well, Jody Simeon graduated in the summer. She earned her master's degree with me. She's now working in industry, and she did a lot of the work that I'm going to share today. Jessie Thrush was an honor student in my lab. She finished in the summer as well. She's destined, or she's going to medical school. Zoe Dean is a current student in my laboratory. She's from Little Rock, Arkansas, honor student in the biology department, and she's working on the current project connecting diabetes and triple negative breast cancer. Calvin Walker is an honor student, a current biology major from El Dorado, Arkansas. Chelsea Perry is a PhD student in my laboratory from Georgia. She's a part of the inaugural Bridge to Doctorate program funded through the engineering department here. Davin is a current student in my cell biology class, and he just joined my laboratory. And Alex was a student in the cell biology class that I teach. He was in there last year, so he just joined the lab as well. So a little bit first about the racial disparity in breast cancer, and specifically in breast cancer mortality. So for Black women, 1 in 9 Black women will develop breast cancer in her lifetime. The age of 59 is the average age that a Black woman is diagnosed with breast cancer. One alarming statistic for us is that Black women twice as likely to develop triple negative breast cancer. So triple negative breast cancer is a subtype of breast cancer, and it's so-called triple negative because it's negative for the estrogen receptor, progesterone receptor, and human epidermal growth factor receptor, or HER2. There are targeted therapies for these proteins, but for triple negative breast cancer, chemotherapies are useful. The tumors are responsive to chemotherapies, but the rate of recurrence is high. So after about 3 to 5 years, tumor will respond, there will be recurrence. Also, these tumors are highly metastatic, and so they like to metastasize to the liver, to the brain, bone, and to the lung. Black women also are more likely to clinically present with advanced stage breast cancer, so around stage 3. Breast cancer is subdivided into 4 stages, stage 1, 2, 3, and 4, with 4 being metastatic breast cancer. In stage 3, you have large tumors. There's some lymph node involvement, so there is some metastases. Also, inflammatory breast cancer can occur at this stage where the tumor actually starts to invade the chest wall and the chest cavity. And so it's demonstrating invasive activity. Another alarming statistic is that 1 in 32 Black women die each year of breast cancer. And the disparity is that Black women are 43% more likely to die of breast cancer in comparison to white women. So some things that can worsen the prognosis of breast cancer: African American women have the highest rate of obesity and are more likely to be overweight. 4 out of 5 African American women are overweight or obese. A Black woman is 50% more likely to be obese than a white woman. 3 in 4 Black women will develop hypertension by the age of 55. Black women are more likely to have less physical activity or exercise. And what's alarming to us in the laboratory is that 25% of Black women by the age of 55 will have diabetes. There's a study that was published in 2017 that stated that Black women that develop diabetes 5 years prior to a breast cancer diagnosis have an 86% greater risk of breast cancer mortality. And so in our laboratory, we want to know why that happens. One thing that happens with diabetes, insulin resistance occurs, and there are various metabolic disturbances that happen in the body. And so patients can be diagnosed with what's called a metabolic syndrome. There are 5 criteria that you have to meet, 3 or 5 criteria that you have to meet to be diagnosed with the metabolic syndrome. And the 5 criteria first are high levels of very low density lipoprotein, low levels of high density lipoprotein, fat around the abdomen, high blood pressure, or high glucose within the blood. The thing about Black people on average, normally, we have a low level of very low density lipoprotein, so low level of triglycerides, and we also have high levels of the high density lipoprotein, so the good cholesterol. Although we have a very healthy lipid profile, for whatever reason, we are more prone to metabolic diseases such as diabetes, such as breast cancer, such as cardiovascular disease. So again, the lipid profile of Black women tends to be healthier in comparison to white women. Low triglycerides, high HDL. But one thing that happens when a Black woman develops diabetes is that her triglyceride levels will stay normal, so there's no change there, but the high density lipoprotein levels will plummet. They'll become lower. And so there's something about that change that leads to the development of breast cancer. So we're trying to understand why. There was a paper that was published in 2012 that stated that Black women with low HDL are at greater risk of developing breast cancer. So in our laboratory, we searched the literature to try to find a protein that could potentially connect breast cancer and diabetes. And there's a family called angiopoietin-like proteins. There are 8 members, and we focused in on angiopoietin-like protein 4. And so there are a few studies that were conducted that gave us the clue or brought this protein to the forefront for us. So Puda et al. Showed that angiopoietin-like protein 4 is involved in liver metastasis and lung metastasis. And this was demonstrated in an animal model. There was a follow-up study by Boss et al. In 2009, and Boss et al. Basically studied messenger RNA. And so we have DNA. DNA is transcribed into ribonucleic acids, and then the RNA is translated into protein, and protein actually do the work in the cells. So they looked at the RNA, and so they found that the angiopoietin-like protein in messenger RNA, the transcript is upregulated within breast cancer brain metastasis. And so we know from previous work that angiopoietin-like protein 4 potentially modulates tumor growth within an animal model. It was shown to be involved in liver metastasis. It was questioned whether or not it actually modulates brain metastasis. It was shown to control the ability to propagate or survive within the blood vessels, and this is necessary for metastasis. It was shown to be upregulated in diabetes, and it also has been shown to modulate lipoproteins, so very low density lipoproteins and high density lipoproteins. And so in our laboratory, we wanted to genetically engineer triple negative breast cancer cells that ask the question of whether it truly drives metastasis. And so what you're looking at on your screen is a normal triple negative breast cancer cell line and a triple negative breast cancer cell line that we genetically engineered to overexpress angiopoietin-like protein 4. And this black band is showing that we actually overexpress the protein. So angiopoietin-like protein 4 is a protein that is secreted from triple negative breast cancer cells, meaning that it's produced inside of the cell and it's released in the extracellular environment. And now it's known that it actually goes to blood vessels and causes blood vessels to open so that cancer cells can enter to develop the metastases. And so we wanted to measure whether or not when we genetically engineer our cell lines, if the cell lines are actually secreting Ang, if it's going to be released out in our animal model. And you can see on the screen that this bar is larger. And so this is a measurement of the amount of Ang that's being secreted by the cell lines that we genetically engineered. So now that we have a cell line that's genetically engineered to express the protein that we think is connecting breast cancer to diabetes, we wanted to use an animal model to test to see if it's more metastatic or if it modulates tumor growth. And so we injected our cell lines in a mouse model, new mouse model, and you're looking at tumors on your screen. So these tumors were isolated from a mouse that we injected with just normal triple negative breast cancer cells. And this group is showing tumors isolated from mice that we injected with the genetically engineered cell lines. And so you can see a difference in size that angiopoietin-like protein 4 is driving the propagation of tumors, and we measured the size of those tumors, and that's shown here. We also, in addition to genetically engineering the cell lines to overexpress angiopoietin-like protein 4, we genetically engineered them to express green fluorescent protein. And the reason why we wanted them to fluoresce green is so that we can visualize them in an animal model. And so this is just showing images from microscopy. The cell lines are fluorescent green, and so that means that we can follow them from our initial site of injection to metastasis throughout the body of the animal. And so we treated 8 mice with the control cell line and with the cell line that overexpressed Ang. and we isolated the liver, the lung, the brain, and various organs from the mice. And so here you can see only one mouse, one of 8, developed liver metastasis. And in the case of Ang overexpression, all 8 of them develop liver metastasis, but we're only showing 4. And we can tell that the cell line is causing metastasis by the green tumors that's shown here. So we also looked at the brain. In order to do this, we had to do intracardiac injection. So we took our genetically engineered cell lines and our normal cell lines and injected into the heart of the mice to allow the cell lines to go into circulation and to basically land in an organ of its choice. And we looked at the brain after we did this assay. And on the screen, you can see 2 brains, one from the control cell line, and you only see 1 tumor. When we genetically engineered that cell line to overexpress Ang, it highly induced brain metastasis. We found on average in each mouse about 9 lesions, metastatic lesions. So the next question we asked, we know that it's driving metastasis, we know that it's driving tumor growth, but now we wanted to see if it's doing anything else within the cell to cause cancer development. And so we took the protein sequence of angiopoietin-like protein 4, put it in a database, and the database suggested that it's going to the nucleus. And as you know, the nucleus is the site of where our DNA is housed. And so we took those cells to verify our findings from the database. We took the cells, we stained the nucleus, and then we stained for Ang to see if it's in the nucleus as well. And so you're looking at a picture of a nucleus stained blue. We also stained for angiopoietin-like protein 4, we stained that yellow. And this is a cell line that we didn't genetically engineer, so there's no Ang in the nucleus, but when we overexpressed it, it was found within the nucleus. So Black women typically have breast tumors that are enriched with stem cells. And so we asked the question of whether or not angiopoietin-like protein 4 is driving the development of stem cells. And so we do an assay called a Mammosphere formation assay. And when we grew the colonies, the cells in culture, mammospheres did form for both cell lines, but the Ang overexpressing cell lines develop larger mammospheres, which that means that it's enriching basically for stem cell formation. So the next question we asked is whether or not Ang is modulating lipoprotein formation or the retention of triglycerides or cholesterols within those stem cells. And we did an assay where we stained our cells with a dye called OR-Red-O. And OR-Red-O basically detects lipids within the cell and cholesterol within the cells. The darker the red stain, the more likely the cells are retaining lipids. And so in this panel, you can see that there is the darker red color, and it means that Ang is actually driving the retention of lipids. And so it's doing something to alter lipid metabolism. Our preliminary findings is basically that angiopoietin-like protein 4 is driving primary tumor growth and liver growth. It also drives brain metastasis. It goes to the nucleus where we suspect that it's modifying DNA in some kind of way. We know that it associates with DNA. So it may be driving epigenetic modifications or transcription to turn on genes that's involved in cancer development. We know that it is enriching for stem cell formation. And again, tumors from Black women are enriched with stem cells in comparison to other races. And it's also causing a change in the retention of triglycerides and cholesterol. And so we are now doing work in the laboratory looking at the crosstalk between our cell lines and diabetic cells. And we are also using a new mouse model where we are inducing diet-induced obesity. And this will eventually, the mice will develop insulin resistance and then diabetes. And so we'll see how our cell lines interact with that microenvironment and see if there's an enrichment of metastasis and tumor growth. So our research has been supported by the University of Arkansas for Medical Sciences, Arkansas Breast Cancer Research Program, the University of Arkansas Chancellor's Grant for Innovation and Collaboration, and the Arkansas Biosciences Institute. Thank you.
Oh, thank you, Dr. Bailey. That was fascinating and also, again, so uplifting. I spend most of my day thinking about dead people. And so it's so nice to hear about somebody who's working on things that will help people to live. And so thank you for sharing that. We've had quite a few questions come into the chat. I would hope that Dr. Bailey and Dr. Hearn, actually, if you would go ahead and unmute yourselves so that you can be ready for questions and we can have more of a kind of dialogue going on here. I want to start by saying that Dr. Balinga had some questions that he answered in the chat that might not have been available earlier are available for all the participants to see. And where did I put those? He was asked by Dr. Valandra about whether he had any data or if it was anecdotal evidence that he was using in regards to how patients were regarding the race of their doctor. And he noted that it was largely anecdotal. And so we have some other things that will go on that he had some questions, but let's move to the questions that we do have for Dr. Hearn and Dr. Bailey. If I could start with Dr. Hearn. Dr. Valandra asked if all of the Black group were Black Americans, and I had a similar question come into the chat of were any of the participants in the study Black international students? And so we were wondering if you could speak to how do you think that intersectionality would change these results, or talk about your data set a bit more.
Sure. So to Dr. Valandra's question, well, let me back up some. So again, these data were collected by the Pew Research Center, and these are nationally representative, so they're not restricted to students. But to Dr. Valandra's question, in the survey, the interviewer would ask if someone identified as Black or African American, and then they might present the examples of Negro, Kenyan, Nigerian, or Haitian. But that's the extent to what I know about how that data was collected. And then as far as the international aspect, again, it wouldn't be restricted to students, but as far as international, I did control for nativity in some later models, and the findings for Black people, Black graduates that is, compared to white people with a graduate degree remained the same. The difference came about when thinking about Hispanic respondents, which is why I ended my presentation saying that if I could disaggregate the Hispanic group, then the findings would likely change. And it was largely driven by the fact that nativity would change those findings, such that Hispanic people with a graduate degree reported the higher psychological distress compared to Black people with the graduate degree as well. The reason why I did not do this is because of cell sizes, or in other words, there were too small, the N was too small, the sample size was too small to disaggregate the Hispanic ethnicity category.
Excellent, thank you. Dr. Bailey, we have another question in chat that is asking, it starts with context. It is widely known that diagnostic criteria, medical trials, and approval for treatments largely rely on the white population as models. Do you think this may explain some of the patterns seen in rates of metastasis and death in Black patients with breast cancer?
Well, the reason for the prevalence and the disparity in breast cancer mortality, it's a lot of things. It's access to care. It is also a lot of Black women don't like to participate in clinical trials for the reasons that you talked about during your introduction. And so it's hard to test these women for the drugs that may be beneficial to them because they don't come to the forefront. And so the reason for the disparity in outcomes is multifactorial: access to care, previous experience, experience with clinicians, a multitude of reasons.
Dr. Hearn, to continue with the theme of women and their interaction with the medical community, I'm going to step in and add my question to a question that was in chat. Somebody in chat asks, if you were to narrow the study down again to just Black women, who are the most educated group in America, how do you think the results would change? And I'd like to add on my question that we're seeing disproportionate amounts of stress for women as part of the pandemic. And I'm wondering how that idea of women interacts with this as well. So questions about women in education and women in stress levels, if you would.
So first, I would say that, the often cited, Black women being the most educated, you might want to dig a little bit deeper into that because there are some complexities there about that finding in particular. Now, Black women are high, there are a lot of highly educated Black women, but again, like I said, as far as doctors are concerned, only 7% went to Black people generally, and most of those Black people would have been Black women, yes. So Black women are more likely to get these degrees more than Black men. Now, if I limited the sample down to Black women, then that means that I would be trying to figure out whether or not Black women across education reported differences in psychological distress. And I think the same things would probably emerge. That is, the highly educated would probably report lower psychological distress compared to their peers or Black women peers who do not have a college degree. And this is for the same reasons that I highlighted earlier. One, education is positively related to income, which is again another another asset or psychosocial resource, as well as a material resource to help lower distress. But also those Black women, those highly educated Black women would more likely have cognitive resources or familial relationships that help them to make social comparisons or draw on their knowledge of resiliency within Black communities. And so I think that all would remain the same. To your question, Trish, I have another study that in which I look at Black women as far as their marital or family arrangements. And so I am comparing people who have never been married, those who are cohabiting, and those who are who experience marital disruption, and those who are married, and their psychological distress averages. And interestingly, what I find is that Black women do not, unlike Hispanic and white women, Black women do not report higher psychological distress compared to their male peers. But when I restrict that down to people who are married, it is Black women and white women who report higher psychological distress than their male peers. And they, in fact, Black women and white women report similar distress, and it's higher than everyone else. And so in that particular paper, what I argued is that Black married women likely have a great deal of familial family responsibilities. But in addition to that, by being married, they also have extended family who probably need a great deal of help at the beginning of the COVID-19 pandemic. So you can imagine if you're worried about your own family or your family prior to marriage, right? And they may need help, but then you also have a spouse or a partner who their family also needs help. And so it opens you up for more requests for help. But in addition to that, the same things that you may have already heard about, there are greater childcare needs. There's a greater need to balance work and family. And most of this, or disproportionate amounts of this, fell on women, and married women at that.
Thank you. I would also say it feels like for academic women, there seems to be, for your academic family, it has also had an undue movement there. Thank you so much for that. I want both of you, Dr. Hearn and Dr. Bailey, if you would think about questions you might want to ask one another as I bring up one more question for you, Dr. Hearn. This comes from the chat again. I am wondering about the impact of racial unrest during this period as well. For educated communities of color, especially Black people, perhaps COVID seemed relatively less distressing. Similarly, to what extent do you think there could be some advantage to communities that regularly confronted racism and microaggressions at work, that is, educated by BIPOC who work in PWIs, and being removed from that environment during the pandemic, and thus decreasing the distress overall?
So as far as the results that I presented today, again, the data were collected in March and April. And while, anti-Black racism has been around well before the murder of George Floyd, these things came to the forefront during that time, which happened in May. I hope I'm not misspeaking there. And so these data were collected prior to that. Now, the interview data that was mentioned, supported by the Arkansas Humanities Center, those interview data were collected in June and July. And I can say that all of the respondents, with the exception of maybe one or two people, and there was a total of about 14 respondents, they all mentioned the racial unrest, and they mentioned how it was distressing. And now I can't, with any great deal of specificity or certainty say, well, COVID was less distressing than the protests and all of that, but I can say that these things work together to cause distress for highly educated Black people. I should have said that that interview sample was with highly educated Black people, so people who held a bachelor's degree or higher. So throughout those same interviews, though, people would say things like, but I'm not the best representative for folks who are really going through it right now. And again, these are highly educated Black people. So they were working from home. They also had lost family members to COVID. They also were dealing with parenting demands. And they would still say things like, but I'm advantaged. At least I can afford healthcare, or I'm not the best representative of this, or my wife and I, we have a higher level of education. So, and so these Black people were always trying to reframe the problem instead of focusing on the immediate stressors in their own lives. They were willing to reframe these problems and focus on gratitude and appreciation for the things they have, which if they were comparing to people that are close to them, oftentimes those people didn't have as much. And so they had a closer reference group to make those comparisons. Now, as far as the second part of the question, if I understand correctly, people who work in let's just say PWIs or people of BIPOC people or populations, well, I mean, on one hand, you could imagine that distress would be decreased if you're no longer going into those spaces. And anecdotally speaking, perhaps I would agree with that. But at the same time, there's also some frustration of not being in the loop, and also not being satisfied with the things that are happening within institutions to address those larger problems. And so just because I'm at home doesn't mean that I'm not still upset that nothing with teeth is being done to address those problems.
I'm really struck, Dr. Hearn, by the empathy that comes out from your interview subjects and their sympathy and empathy that they express towards others. And that actually brings up a question we just got in the chat for Dr. Bailey. The question is, what got you into breast cancer in Black women as a study area? And while learning the information by data in your studies, does it tend to affect you emotionally of how high the rates are? Also, to add from Dr. Belinga, how a lot of African Americans are less likely to go see the doctor. Do you know how many African American females tend to be untreated or not treated in time for breast cancer?
So my whole reason for studying breast cancer, triple negative breast cancer, stems from the experience that I've had with my own family. So I grew very, very close to my grandmother. I heard stories about how she lost her sister to breast cancer, and so that impacted my desire to want to go to medical school, but I ended up doing research. In 2019, I lost an aunt to breast cancer and diabetes, and so that led to the studies that I'm doing now. That was a tough loss for me. My mother, she's had several what we call scares with the identification of tumors within her breast, and I myself have had multiple benign tumors removed from my breast. And so that connection is driving my research. It's very, very real for me. And I'm not really surprised by the outcomes, just because I'm from a very small area in Arkansas, and a cancer center is about 75 miles away. And so it's very hard to get access to care. It's very hard to find people to talk about what's going on with their body. And so I'm not really surprised what the literature is saying about the outcomes. I'm not really surprised about the disparity. And when you talk about chemotherapies and radiotherapies and et cetera, it's very hard because of the distance and the connection that Black people have with clinicians to stick to a regimen and stick to chemotherapy. So again, not surprising with the outcomes. And one thing that kind of has surprised me, Black women, when they do have good access to care and are in a good clinical setting, that on average, they tend to, for whatever reason, refuse radiotherapy. I don't know why that is, and that's something that I would like to study. But in terms of the rates and outcomes, not surprising at all, just because of what's happening with my own family and in my own town.
Thank you. I want to thank both of you for sharing with us your research, your scholarly passions, your empathy in these answers, and your relationship to your subject matter and to the people that you're trying to help with your research. I liked Carrie's statement at the beginning about how you are part of our communiversity and showing how the university is intimately connected with helping and helping our community and helping people to live better lives. And I'm glad to have been part of this today. I think that is it for our questions. I was going to turn it back over to Professor Benton. Oh, no, she just said no. Okay, all right. I want to reach out and thank Sinitra and Sarah so much, because we would not have this at all without their help. And thank Dr. Benton, who's on my other screen saying, no, 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 don't put me back on the screen. Thank you so much. Thank you for joining us. And please do look into tonight's lecture. And let me pull that up again, from Dr. Yefunyewe, and Containing Contagions, Overlapping Pandemics of HIV, COVID-19, and the Global Black Community. This will be taking many of the stories that we talked about today about access, about treatment regimens, about simply being able to talk to a physician, and taking that into the larger global community and discussing how access to care is not just a local issue, it's not just a national issue, it's a global issue for not just COVID, but for all sorts of different conditions. And so I think that's going to be an excellent talk. I'm very excited to see what he has to say, and you can still sign up for that. I believe, can we put a link in the chat to that for anybody who's interested in that, please? And otherwise, thank you for being with us. And I hope you have a good day. And as I tell my students at the end of history of medicine classes, let's go with Hippocrates. First, do no harm. Thank you so much.